Let's learn about the infection in immunosuppressed in detail. Let's learn about COUT criteria, that is catheter-associated urinary tract infection criteria. It is defined as a patient when patient has an indwelling catheter that has been placed for more than 2 days on the date of event and was either present on any portion of the calendar day on the date of event or removed the day before the date of event. The patient had at least one of the signs and symptoms like fever, suprapubic tenderness, costovertebral angle pain, urgency and frequency, and dysuria. Urine culture with no more than 2 species of organisms identified, at least one of these had a count of more than 10⁵. So that's the definition of a CORT, that is catheter-associated urinary tract infection. There are many studies which have studied the strategies to prevent catheter-associated urinary tract infections in various settings. And there are two main principles for the prevention of catheter-associated urinary tract infection. One is avoid unnecessary catheterization, and second is limit the duration of catheterization. Unnecessary and limited duration. Now, what are the indications for the catheters? It should be perioperative use for surgical procedures, urine output monitoring, management of acute urinary retention, assistance of pressure ulcer healing, and as an exception, a patient request to improve comfort. But it should, urinary incontinence should not be an indication for catheterization. 20 to 50% of the catheters are not indicated as per current. Now, is one catheter better than other? No, there is no significant difference between latex as well as silicone catheters. Also, the impregnated catheters, the concept is to prevent a biofilm formation. So, antimicrocoated catheters are only indicated for the prevention of biofilms. Currently, it is not recommended by any of the guidelines for upon regular routine. The catheter insertion and maintenance, the care bundles include first is to practice hand hygiene before insertion of the catheter and before and after any manipulation of the catheters. All the 5 movements and insert the catheters by use of aseptic techniques, cleanse the middle area with antiseptic solutions, properly secure the catheters after insertion, maintain a sterile closed drainage system, and do not disconnect the catheter and drainage tube unless the catheter must be maintain obstructed urine flow, unobstructed urine flow, empty the collecting bag regularly using a separate collecting container for each patient and avoid allowing the drainage spigot to touch the collecting container. Keep the collection bag below the level of the bladder at all times. Do not routinely use silver coated or other antibacterial catheters. Do not screen for any asymptomatic bacteria and do not treat asymptomatic bacteria in catheterized patients. Now, what you should not do to prevent COT, that is to do not use catheter irrigation, do not use systemic antimicrobials, do not change the catheter route. And bear the first principle of infection prevention, that is use of catheters, use of ascorbic acid lines, and therapy of primary functions, experience with surgical procedures, and hand hygiene standard precautions. At least 30 to 50% of all infections are associated with this 5 patient care. Now let's learn about COT. Let's learn about CLABSI. That it's a central line associated bloodstream infection. It's defined as a lab-confirmed primary bloodstream infection where central line was in place for more than 2 days on the date of the event, with the date of device placement being day. What is the central line? It's a catheter which is intravascular and terminals are close at or close to the heart in one of the great vessels, which is used for infusion or withdrawal of blood or hemodynamic monitoring. Example: aorta, superior and inferior vena cava, pulmonary artery, external iliac vein, common iliac vein, and others. The sources of catheter-associated bloodstream infection would be intraluminal from tubes and hubs, then extraluminal from the skin, and then hepatitis spread from. How to prevent this? As you hand hygiene, then maximal barrier sterile precautions, skin antiseptic with alcohol-based chlorhexidine antiseptic. The subclavian access should be the preferred site. Daily review of the line. Standardized catheter care using a non-touch technique and respecting the recommendations for dressing change. Here are the articles for the details. Now, could we do better as chlorhexidine gluconate and impregnable response could be applied to at the dressings to maintain the sterile conditions for the central lines. Chlorhexidine gluconate implant dresses decrease the major catheter line infections. It was observed that about 1.4 to 2 it was reduced to about 0.6 per 1,000 catheter days. That is sponges. That was about CLABSI. Let's learn about ventilated pneumonia. This is infection with onset of 40 to 72 hours of hospitalization, development of new infiltrates in chest X-ray, fever, leukocytosis, and purulent tracheobronchial secretions. This infection was neither present nor incubated at time of. There are many various factors that are responsible for ventilation pneumonia, like host factors, surgery, medications, invasive devices, respiratory therapy equipment, which lead to oropharyngeal colonization and gastric colonization, which in turn leads to aspiration. And depending upon the number of bacteria, that is the density and the virulence, and depending upon the lung defenses, which if it is immunocompromised or suppressed, then it may lead to bacteremia and translocation to other sites and develop pneumonia. Risk factors for this pneumonia include the age, burns, coma, lung disease, immunosuppression, malnutrition, blood trauma, then invasive ventilation, duration of the ventilation, reintubation, medication, and others. Precaution includes staff education on hand hygiene and isolation precautions, surveillance with timely feedback and adequate staffing levels. Ventilator measures include avoid intubation and reintubation, prefer non-invasive ventilation, prefer orotracheal intubation, have a continuous subglottic aspiration, compressor should be maintained more than 20 centimeters of water, avoid entering of contaminant condensate into tube, use sedation and weaning protocols to reduce the duration, use daily interruption of sedation and avoid paralytic. The fraction of oxygen in inspired gas is critical. It can be adjusted depending on the patient oxygen needs. Range is 30 to 100%. A sustained increase in the daily minimum fasting increment of oxygen following a period of stability or improvement is the second of the two criteria that can be used in meeting the ventilator acid condition definition. Selective decontamination of the digestive tract reduces the incidence of VAP and helps to contain MDR outbreaks. But as it is not recommended for daily use, prior systemic antibiotics help to reduce the VAP in selected patient groups but increases the multi-drug resistance. 24-hour antibiotic prophylaxis helps in one study but not for trace breeding. There is a trend towards less VAP with sacral fat, but increased gastric bleeding is an issue. Prudent transfusion like glucose depleted RBC transfusion, intensive insulin therapy are of use in prevention of ventilator pneumonia. Then semi-recombinant position, that is 40 to 44, 30 to 45 degrees, especially when receiving enteral feeding. Then enteral nutrition is preferred over parenteral because of translocation. Then added to the hand hygiene, added to glow and gown use, back rest elevation maintenance, correct tracheal cuff maintenance, orogastric tube use, gastric over distinction avoidance, good oral hygiene and elimination of non-essential tracheal section are part of the various multifaceted measures to prevent VAP. Hand hygiene before and after patient contact, and avoid intubation, intubation if possible, use of oral rather than nasal tubes, minimize duration and promote tracheostomy when ventilation needed, and glow and gown use. With non-essential tracheal secretions, oral hygiene with chlorhexidine, back rest elevation, maintain cough pressure more than 20, avoid gastric cord distension, promote the enteral feeding and careful blood sugar control, and SGD in selected cases.